Great. So get used to that technology. We're going to be using it throughout the day, and we really want this to be very interactive. As you can see, we have a very full room, and as I mentioned, we have a couple hundred people. We'll get a count for you of how many people are actually joining us via webcast when we can. But there's no way we can, address everybody. This is one way for us to really continue to get everyone's input and continue to make sure that we're connecting. So now I'd like to introduce Annie Levy. She's a visionary and creative director, and her work in the world of medicine has focused on transforming the way we see and are seen, designing large-scale portrait projects that enliven and infuse space. And you can see a perfect example of what Annie has led for us, which is the art installation in the hallway, as well as in room 105, where you see some of the videos that some of the artists submitted. So I welcome Annie.
Thank you. Was that long intro feeling? So thank you, Kimber. It's a thrill and an honor to be here, and the comments so far have been so, my word that I chose for the word cloud was life with an exclamation point. That health is life. And just by way of background, as Kimber said, much of my work has been putting media tools in the hands of people, largely teens with life-threatening illnesses, to show us how they see the world. And we get to see the world through their eyes, through their images, through their videos, and we're changed. But most importantly, and what we're hoping for the exhibit and the website, which we've put together, is that we're not just changed, but we're moved to respond. That we don't just look at art on a wall and then walk away. We look and we understand and we see the world through other people's eyes and we take action. Why art is really the question. And the painting that came to mind was by everyone's beloved Vincent van Gogh, because everyone has looked up and seen the stars in the sky. But we haven't seen the stars the way Vincent sees them. And when I thought about this, I thought, wow, that's really, we never see the stars differently after having looked at this painting. So that would be my answer to why art, because we do see the world differently. The Academy graciously allowed me to write something for the opening panel, and what I chose, if we could go to the next slide, was a quote by Jacob Riis, who is a giant in the field. I see someone nodding. A giant in the field of changing culture through photography. He couldn't bear what was going on in New York City tenements and documented it, and change was produced. But Jacob Riis was not without discouragement and the need for encouragement. And he said, look at a stone cutter hammering away at his rock, perhaps 100 times, without as much as a crack showing in it. Yet, at the 101st blow, it will split in two. And I know it was not the last blow that did it, but all that had gone before. And I think of us here in that room as the stone cutters. One more thing about Vincent, if you will let me. Vincent wrote a letter to his brother, Theo, and he said, Theo, maybe someday I'll have a painting in a small cafe. And it made me think that we don't know the work we do here, the impact it will have as a stone cutter, or that maybe someday the work will go beyond one painting in a small cafe. So it's with that sense of humility and persistence that I am thrilled to be here and introduce our first stone cutter, Shaneah Taylor, who, after we hear Shaneah, we can basically go home. Shaneah, and I'm going to read the bio, but stop me if it's too long. Shaneah is currently a research manager at Northwestern University, where she directs the Chicago CHEC Research Fellows Program, which is responsible for introducing minority undergraduate students to the Physicianscientist Pipeline. Shaneah is also a lecturer and advisor for an online healthcare career course and liaises with Chicago Public Schools routinely to strengthen the blended classroom instructional approach in reference to the health science curriculum. You're giving me the, okay, but I like this. In her spare time, she's a podcaster, a traveler, an avid lover of discovering coffee shops. So please welcome Shaneah Taylor.
Thank you so much, Annie, for that introduction. And it's really a pleasure and an honor to be here. And if it's okay, I'm just going to go right into the poem. Let's see. Am I able to use this handheld? Okay. Can y'all hear me? Okay. Health equity is community. It's an honor to provide you with a poetic summary of what this means to me. But as I contemplate deeply, health equity supersedes the consideration of you and me. It's the ability to tackle disparities widely and innovatively. It's leaders, researchers, educators, and policymakers intersecting. It's abandoning the notion that health equity should be prefaced with contingencies. It's healthcare workforce development for young people across every community. It's the provision of medical care for all, irrespective of socioeconomic status. See, when machines for mammography are distributed liberally, when my pockets are empty and my breast lumpy with undiscovered malignancies potentially, I will no longer have to worry about whether or not hospitals will thoroughly serve me. That's health equity. My city is plagued with flying bullets that seem to outnumber the birds in the sky. I don't pretend to know why, but if trauma centers were remotely as prevalent as guns were present, maybe we could save more lives. Our neighborhoods are baptized with unending cycles of poverty while food deserts cover acres and contribute to the spread of chronic disease. Health equity is access to classes on how to plant a garden of seeds. Health equity is community, coming together from great-grandmothers to toddlers, equipped with messages of prevention from mom and pop shops to bus stops named as headquarters for public health interventions, a vision of health and wellness etched on highway billboards instead of insurance plans that I can't even afford. True health equity isn't safety based on geographic location or zip code or referrals into clinical trials based on the caliber of people that I happen to know, but it's the access to quality services no matter the color of my skin, no matter my immigration status or ability to fit in. Health equity is embracing the mistakes of the past and learning lessons so that we will never repeat. The reinforcement of medical mistrust in our minority communities. Health equity is planting the seed of opportunity in minority youth, that healthcare careers are definitely an option, and just because politics change and budgets fluctuate, that's no reason to stop them. I don't want poverty to be an inhibiting factor to educational opportunity. Career success should not just be a possibility, but we have the power to infuse young dreams with reality, opening the doors of academic institutions and welcoming students from neighboring communities. Exposure to research and high-level mentoring affects their individual career trajectories. That's what matters to me. It happened for me. I am a beneficiary from where we sit. We already have this grand repository of resources, tools, and seeds, and if we consistently commit to spreading them indiscriminately, finding the beauty in our differences and embracing the similarity in our humanity, that's health equity. Health equity is community. Thank you. Thank you. Thank you. Thank you all so much. Thank you. Thank you. Thank you so much for that ovation. So I'm supposed to say a little bit about the inspiration behind this piece. This has really come from all of the experience that has shaped my career thus far in public health. And this includes my current work, as Annie spoke a little bit about, with helping to design and implement a pipeline fellowship program that helps minority students. It's all come back to and down to digesting the voices of those that experience health disparities on a daily basis. So this piece was really inspired by the voice of the patient, the voice of the prospective minority physician, and of family members that are still struggling to get the health care that they need. And in my work at Northwestern, I'm able to encounter minority students in particular that have benefited from our fellowship program that, had it not been for intentionally focusing on embracing a diverse applicant pool, they otherwise may not have been exposed to resources to guide their careers. So thank you again for this opportunity.
Now, I'd like to introduce Emily Kragle. Emily, admittedly a difficult act to follow, but your work is beautiful, so please come with gusto. Emily is a Benjamin N. Duke Scholar. She graduated in 2016 with a degree in visual arts and computer science from Duke University. During her undergraduate career, she was awarded the Dean Summer Research Fellowship to conduct research on barriers to healthcare access in Guatemala while working with the Primeros Pasos Clinic. In addition to the research presented here, this work in Guatemala led to the creation of a visual arts project that's beautiful, that was awarded the Sue and Lee Noel Prize. She's currently pursuing her MD degree at Brody School of Medicine in her hometown of Greenville, North Carolina. And a coffee enthusiast, or? No, okay.
Hi. Thank you guys so much for having me here today. I'll start out just by describing kind of what I did when I was in Guatemala and what led me to this and the inspiration for this piece. So I worked in the Palahuna Valley. It was a very rural community with indigenous population. And I really spent a lot of time with the nutritional recuperation program of Primeros Pasos. They work with mothers of children under the age of 2, doing cooking classes and nutritional education and community gardens. But I had a limited time there, and I wanted to be as useful as possible. And from spending time with the community members, I decided to do a research project on kind of the barriers to healthcare access and also the factors influencing healthcare seeking behaviors. So I did a lot of research, background research, and figured out what might be going on before I talked to all these women about these factors that included geography and physical access to care centers. Be it in the valley there's the folk sector of health, so like midwives and traditional healers that are located within the communities and are very close physically. There's also the Primeros Pasos, the nonprofit clinic that was closer than the public health posts, which was the other option. And so in talking about this issue and this theme, you realize how physical distance really is such a barrier, and relying on chicken buses for transportation, or I think there's someone riding a bike there, but the roads aren't paved, and it's a really difficult barrier that these women faced and people in these communities faced. So that's this. There are 3 parts to this series. I don't know how to go to the next slide. Is there a? Oh, there we go. Okay. So another factor that I looked at is that one. Okay, thank you. Was machismo. And it's not actually something that I saw through the research that I did, and I think there was a lot of sample bias in the research that I did because I interviewed women who were already participating in this program, so they were already overcoming some of these barriers to healthcare access. But from talking to them and from my research, machismo in this male-dominated culture where the males are the decision makers of the household really affects some of the ability of women to seek healthcare or care for their children in these communities. And so in this picture, there's a lot of shadows and dark colors kind of covering the women, and these are the women from the nutritional recuperation program. And so that kind of reflects this theme of machismo and ability to seek healthcare access. And then the last one is relating to the idea of beliefs about certain illnesses. So from these conversations and from going back and doing some inductive reasoning and qualitative analyses, we realized that there are 3 kind of categories of diseases. There were cultural illnesses like mal de ojo and lombrices and perdida de alma that are all stem from an imbalance in heat or energy. And if a child was afflicted with one of these illnesses, the mothers would take them to a midwife or a traditional local healer to be cured with traditional remedies. But if this doesn't work, or if there was a more serious illness, then they would seek medical attention from the public health post or from the nonprofit clinic. And then there were some diseases that were just considered incurable or untreatable, and they wouldn't go seek any care for these conditions, and that was diabetes and cancer were the 2 that came up most commonly. So this one, I was kind of thinking of perdida de alma, which is a loss of soul. So you kind of have the color and the black and white and the visualization of that particular disease. So that was my project and the inspiration behind these 3 pieces. I loved working within the community and getting to know the community members and their specific challenges, and that's really how that clinic Primeros Pasos operates. And I think it's part of the reason why they're so successful, because they constantly adapt and develop their outreach programs and services to meet the needs of their community members. So yeah, that's it.
Thank you. I feel like we're in a call and response. Like there's the art, and then there's the what are the programs? What are the so the next artist I would like to introduce is Samuel Mendez. He's a filmmaker and community engaged researcher, focusing on how to use digital media to center the voices of traditionally underserved communities in discussions of promoting health equity. He graduated from Harvard with a degree in visual and environmental studies and went on to produce web video projects internationally. His work includes a travel series highlighting barriers to wheelchair accessibility in major sites of interest in Ho Chi Minh City. He currently works as a member of the Simon Lab on community-based research projects. And spoiler alert, you have to go online and watch the ending of this video for the credits. Samuel.
I think we can start off by playing the clip. I'm not sure.
Sí, eso es lo bueno, que aquí estamos como entre familia. Usted que entra aquí se siente como familia.
Buenos días. Se le da la bienvenida.
Sí, se siente como familia.
Se saluda
que es
con
una parte muy cultural de nosotros.
Sí.
Que yo creo que es otra cosa también, que la bodega es una cosa más cultural.
mucho más que supermercado.
Oye,
No, no.
nada más.
So I just wanted to talk a little bit about the inspiration behind the piece. The full film is available online. Those are a few selected scenes. I was really interested in taking an asset-based look at food access in Lawrence, Massachusetts. I think it has, as many underserved communities do, a certain image in media that is sort of framed on the problems and focused on the resources that are lacking. And while that is important, I do think it is also important to respect the work being done at a local level and by community members where inequity and inequitable social systems have sort of left gaps to see what people are doing to fill those and what resources and efforts can be strengthened in our work towards health equity. So I was also really interested in how to use art as a way to make some of these complex topics more relatable and more memorable. I think it's one thing to be able to make a more traditional documentary that walks you through some of the facts and processes of how these things and these situations come to be, but it's also very powerful to make more of an emotional connection, to be able to remember and empathize with what it feels like when you have these familiar foods that you're able to make the food that you know and love and grew up with, and to have these sort of, in this example, these local store owners in corner stores in your city, listening to your needs and being able to provide an opportunity to get the things that you need to thrive in your everyday life. And so that's something that I'm interested in pursuing longer term, is how do we make more of these empathetic and emotional connections between communities and the work going on already to address health equity, and form those bonds with people on the policy and research side to be able to get some streams of work that respond pretty directly to people's ongoing needs.
Thank you, Samuel. Our final artist who is here today, Connie Heller. Connie is an artist, strategy, design consultant, and philanthropist. In her art, Connie uses the medium of fiber collage to explore and reveal the complexity of race in America. When she is not in her studio, Connie collaborates with academics, philanthropists, and grassroots leaders to create learning spaces to share research and strategies to address structural racialization and implicit bias. She is the co-founder of the Linked Fate Fund for Justice, which supports grassroots organizing and intermediaries working to end systemic racial inequity. Connie.
Thank you, Annie. Thank you all for inviting me to share my art with you. It's a real honor. And Annie, I really appreciated your starting with the reference to Van Gogh. I actually just started taking my own art very seriously after spending a summer in the Netherlands and seeing an exhibit where Van Gogh only worked for 10 years. And I thought, you know, if I could have the potential to change the conversation the way Van Gogh has, in 10 years, I should give it a shot. You know, because all of us, we're working so hard. And so it gave me some perspective, which I really appreciated. So I began working in fiber collage just as I was beginning my journey to understand the complexity of race in America and the systems of oppression and exclusion that shape that. And as everyone in this room knows too well, health is determined by the social determinants of health, including housing, jobs, education, and so forth. And the inequities that play out in housing and jobs result from racism and imbalances of power that play out in these different spheres. I feel like the microphone is a little funny. Is it okay? Okay. So I really, myself, as I was learning about this, was feeling quite overwhelmed by the breadth of racialization and the depth of its impacts. And I needed a vision. I needed something to visualize where I was going, where we were going. And I needed something that I could hold on to as I navigated complex conversations in philanthropy, which is this space where I do most of my work. Collage seemed like the perfect medium, made of scraps with unfinished edges, roughly, chaotically stitched together. A project that is always forever in the making. So when I made this piece here, Imagine Belonging, I had just completed a piece about othering called White, Not White. In that piece, I explored the making of inequity and how it is achieved through racialization processes. In making that piece, I came to understand how racialization shows up differently for different groups, but at the end of the day are all variations on the theme of manufactured exclusion. Mechanisms devised to divide and separate us from one another, physically, socially, economically, ontologically, spatially, emotionally. The clearest and most extreme variation is represented by the reservation, internment, incarceration, and detention. Needless to say, these conditions and the conditions that lead to their possibility are bad for health and health outcomes. Upon seeing the piece, one of my mentors said to me, "Describing the problem is easy. What is needed are aspirational visions for alternatives." So I went back to work. I began with questions. What would it look and feel like if communities and the people in them believed that everyone belonged? What would it look like if our propensity to other did not obstruct our commitment and our capacity to care for one another. What would we see in communities if everybody in the communities could rightfully demand, concern, and expect full regard in return? So this is where I started to explore those ideas. So people who live in cities, suburbs, and rural areas would recognize their interconnectedness. Because we would not differentiate between worthy and unworthy people, our built environment would reflect our commitment to infrastructure to enable people to live and thrive. Our housing would not be segregated, it would be integrated. We would have sidewalks and swimming pools that were open to everybody. We would have public benches that we could rest and visit with a friend on. We would make collective investments to preserve and create community by structuring places and time off to encourage meaningful connection among and between diverse groups of people. Time off from work as breaks, time for new mothers and new parents, vacations for everybody who works. Through my act of making this piece and creating the scene that is both familiar but also aspirational, I hope to demonstrate that we have the capacity to design and make laws, policies, and practices that build and structure an inclusive society, a society that evaluates its success by how well it has achieved belonging, knowing that belonging is a precondition for racial and health equity. So returning to this question about how art helps us wrestle with complex issue. Art creates a spaciousness to imagine possibilities that might otherwise seem impossible. Art invites the artist and the viewer to ask new questions, engage with an experience not our own. Art reminds both the artist and the viewer that the world around us is made and designed. It is not natural, inevitable, or even neutral. Art opens us up to have the courage to imagine how we might live and work in new and unfamiliar ways. Art allows both maker and viewer to connect directly with our deepest human selves, connecting us to the humanity of our would-be others, opening our eyes and then our experiences to our similarities without diminishing the significance of our differences. Thank you.
No. So this is a bit of a lightning round because we're a little short on time, but we wanted to have a brief Q&A at least, and please come ask us questions afterward. It would be lovely to have more conversation. Shaneah, so your program that you work on introduces undergraduate students to the Physician-Scientist Pipeline by giving them access to physicians through lectures and research. How is the physician pipeline? How do you see it as a health equity issue? And why do you think it's so critical to engage the young people?
Thank you for the question. The Physician-Scientist Pipeline in itself is not a health equity issue, but I think when we fail to expose students in underrepresented environments to that pipeline and give them the resources that they need to gain entry into the pipeline, that's when it becomes leaky and incomplete. I used to work in a charter high school in Chicago, and it was a low resource school, and students didn't even know healthcare careers beyond a doctor or nurse. Students didn't think they could gain entry into medical school because they didn't have any money. So I came from a high school where, thank God, I was able to go to France during my high school career. So these are some of the disparities that exist in our educational system. And I think that those of us that are part of higher level institutions, community-based organizations, we have to do what we can to reach back into these communities and get these students that are really well performing, but they just need an extra boost, an extra ushering into some really prosperous and high-level careers that will really help them. So we have to remember to help our students and not forget about them.
Thank you, and thank you for the phrase leaky pipeline. That's a brilliant phrase. Emily, you're a first-year medical student. Your experiences in Guatemala seem to give you amazing insight into life there. Can you tell us, is there a vision you have for the lessons learned and impact, using that in your medical career, your journey?
Yes, so thank you for the question. if I had to summarize the lessons that I learned in Guatemala, one would be the need for individualized treatment and the need to really understand people as people and not a list of symptoms or a list of problems. So in my practice as a doctor, I hope to incorporate that into just my daily patient-physician interactions and really listening to my patients and their story and their needs. But also, as a secondary lesson, I really saw the importance of looking at social determinants of health and looking at what happens beyond the walls of a clinic. So I hope in whatever medical practice I go into that I can expand it beyond the walls of a clinic and do sort of interdisciplinary work. And I'm actually in a really unique position now, and I'm kind of trying to start to do that. So I'm in Greenville, which is where I'm from originally, and I grew up seeing the disparities that exist within that city and the health disparities that exist. And so I'm leading a group now. There are really high rates of obesity and cardiovascular disease and diabetes, and food access is a problem, especially in schools and with some of the younger population. So we're working on doing a community garden project and some nutritional education lessons. So, yeah.
Thank you. Sam. So in order to create your film, you went into the communities, you talked with the people who may struggle but want to find their own community-based solutions. Can you expand on some of what you gleaned from working with the community members? Are there stories that...
Yeah, so the film took place in a corner store in Lawrence, Massachusetts, and at the time there was about one supermarket for 75,000 people, so food access was a large problem in the city. And so it was very interesting for me to see connecting with the Lawrence Mayor's Health Task Force and local business owners who were working together to address parts of this issue. It was really motivating to see how in touch with the community members' needs the local business owners were. And you can see that reflected in the sort of cultural tailoring of the food that they knew people would want because they were part of that community too, to the way that they even describe it sort of in the beginning of the film, that when you go in there, it feels more like a family and more of a community than just a store. In the beginning, I sort of showed the reverse of the business card of the store, and it has a listing of numbers for social services in the city and in the state. And I think that just speaks to how in tune and how active a lot of people are in solving some of these problems. And I think pointing to streams of work that should be supported by other agencies and other people as well.
Thank you. And finally, Connie, you had mentioned to us that your father was an immigrant to the country, and we're wondering how that shaped your experiences growing up and how it shaped your general experience of health equity.
Thanks. Yes, my father was an immigrant from the Philippines. My mother is white and is from Texas, and they met while my father was running for public office in the Philippines. This has had a really deep effect on my role in this movement. So first of all, both of my families actually came from fairly well-off families. So this was not an issue around class. This was really an issue around race. And I think, to your point, that there's so much resilience in communities, and I don't want to downplay that. I grew up in an amazing community in San Francisco that had people from all over the world. I grew up upstairs from a saxophone player from New Orleans, and it was just a really rich, wonderful place to be. What I didn't realize then, which I do realize now, is that we lived in that neighborhood because it was the only neighborhood in which we could find housing, and it was the only neighborhood in which we could afford housing. And those are choices that we are making. And I think and this is my last point on this, is that I think that we have a way in which when we are only working with professionals, that we like to simplify the story and take out all the nuance. And one of the things that is so important to achieving health equity and racial equity is to bring in the voices of the people. It's not just so that they can feel good. It's so that we can give the nuance of our lives, the complexity of our lives to the stories that people are telling. So we're telling our stories. So that the policies and the interventions that emerge actually address real life, not a simple compartmentalized life. And the one thing that I would say that I haven't heard yet in this conversation today is how important it is to build power in communities and support building of power in communities so people can be active participants in democracy, so that they can self-advocate and really be the leaders of the change. That, you know, that we're not taking care of people, but we, the people, are rising up.
Thank you.